Good evening and welcome to this virtual patient conference hosted by Kidney Wales, the Paul Popham Fund and a range of partners that have helped to make this possible. Today we are going to focus on the rollout of the vaccines that have been developed to protect us against the COVID-19 virus. It is truly amazing that 2 vaccines have already been developed when you think that none of us had even heard of COVID-19, shielding or lockdown this time last year. But we know in a year of firsts and so much trauma, along with the good news about the vaccines, there is a lot of anxiety. The kidney community is unique and most of the information provided so far about the vaccines has been very general and so has left you with lots of questions. Today's conference aims to answer a lot of your questions, which you've kindly posted ahead of this presentation in very high numbers, so thank you very much. If you still feel that your question hasn't been answered, please post your query using the Q&A button. We won't have time to answer them during the presentation, but our responses will be available after the conference on the Kidney Patient Conference website. Joining me today to answer your questions is Professor Chris Brown, Consultant Renal Pharmacist and Renal Pharmacy Lead for the Welsh Renal Clinical Network. We also have an old friend of the virtual patient conferences, Mr. Mike Stevens, Consultant Transplant Surgeon and Transplant Vascular Lead for the Welsh Renal Clinical Network. I'm also delighted to be able to introduce Brett Dowd, Patient Information and Support Manager for Kidney Wales and a hemodialysis patient, who I'm sure many of you know. Brett will be giving his personal insights into receiving the vaccine. All that's left for me to do is to introduce myself. I'm Susan Spence. I am the Network Manager for the Welsh Renal Clinical Network, or the WRCN as we affectionately call it. I've mentioned the WRCN a couple of times already, and some of you may know about us, but I suspect most of you don't. So I thought I'd start by giving a very brief introduction. Next slide, please. This is our beautiful logo, which was designed specially for us, and as you can see, features the kidneys and the Welsh dragon. Next slide, please. What do we do? Basically, we're a group of people accountable to Welsh Government for commissioning or buying all adult specialist renal services in Wales. That is all the dialysis services, transplant and vascular access services. We work strategically in accordance with our delivery plan, which you can see on the slide, and we have an agreed set of service specifications to which we expect all services to adhere so that specialist renal services in Wales are of the highest quality. Next slide, please. The network is really all the clinicians, nurses, dietitians, social workers, pharmacists, etc. that support you. But we have representatives to act as clinical leads in terms of decision making. I've introduced Mike and Chris, but we also have a lead nurse, a patient quality and safety lead, and a health and wellbeing lead, as well as representation from the charities that are hosting this conference today. Although the WRCN are not directly responsible for commissioning things like patient transport, we know how important it is for for it to be available at the right time. So we work closely with WAST, the Welsh Ambulance Service, so we can work together to improve services. Next slide, please. This is just to give you an idea of how widespread the network is and how many patients in Wales we serve. Next slide, please. For dialysis, we have a hub and spoke model of clinical care and support. The 3 regional renal centres in Cardiff and Vale, Betsy Cadwaladr and Swansea Bay support a range of satellite units and of course also deliver on home therapies. Next slide, please. The pandemic has and continues to be challenging. There's really shone a spotlight on the fact that the NHS cannot do everything on its own. Our charity partners have been invaluable in providing care and support for people in need and making sure calm and consistent messaging has been available. Next slide, please. In those lovely days when we could meet each other, Kidney Wales supported our Living Well with CKD roadshow, and we do hope that one day we'll be able to do that again. Next slide, please. In these times when we've had to social distance, Kidney Wales, the Paul Popham Fund and Kidney Care UK, as well as our research partners in the Welsh Kidney Research Unit, pulled together a range of patient newsletters. And I hope you've had the opportunity to read some of them. Next slide, please. Before we go on, a sad reminder of the terrible harm that this virus has caused. A total of 114 people with kidney disease have sadly lost their lives so far in Wales since the start of the pandemic. Patients that have in-centre dialysis have been the most affected in terms of being infected with COVID, suffering severe illness and passing away. We pay tribute to all their loved ones and the dedicated staff who tried so hard to save them and give comfort in their final hours. Next slide, please. But we can fight this battle together. Vaccines are the way forward, and I'm delighted to introduce Professor Chris Brown, who will give us an overview of the importance of accepting the vaccine when it's offered. Thank you, Chris.
Thank you, Susan, and also thank you to Kidney Wales and the Paul Popham Fund for inviting me to speak and also for hosting this evening's event. I'll give you some perspective into the vaccines and some of our own experience with doing this. Could we have the next slide, please? So my name is Chris, as introduced by Susan. I work within the South West Wales region and also for the network on a national level. And joining me for panel questions at the end is also a pharmacist who works with me. Both of us have had first-hand experience in vaccinating our kidney population, and hopefully we'll be able to share some of that learning that we've had firsthand. So next slide, please. So I thought I'd start by making clear that we have a differentiation between what COVID is and what Sars virus is. So COVID-19 is the disease that is caused by the virus. The virus causing the COVID is SARS-CoV-2, and this stands for severe acute respiratory syndrome. And the CoV part of that name refers to the coronavirus, which is a group of viruses belonging to this family. Next slide. So the SARS virus itself is a small entity, much smaller than your typical bacteria. It contains a small amount of a genetic code called RNA. And it is this code of RNA that is the source of the problem. The virus itself cannot replicate outside of a host. It must be present in human cells to reproduce. And this is the mechanism by which the disease is transmitted through interactions with other people. The virus itself has three components, and understanding this gives us some understanding to the effectiveness and how the safety profile of the vaccines work. So the virus has three components. RNA, this is the genetic code that the virus uses to take advantage of the host cell and reproduce itself. It has an envelope which protects and encapsulates the RNA. And it has a spike protein, which I'm sure many of you will have heard. And it's this spike protein by which the virus allows itself entry into a human cell. And it's this spike protein and these RNAs unique to the virus that has given us the opportunity to come up with a safe and effective vaccine. Next slide, please. So Before we move on to the vaccine itself, remind ourselves of what the symptoms of COVID-19 are. And these are a new continuous cough, defined as coughing for more than an hour, or 3 episodes of coughing within a 24-hour period, a high temperature, or a loss or change to a sense of smell or taste. And as we've learned more about the virus and the condition it causes, we've recognized that those aren't the exclusive symptoms. Of course, it can cause fatigue and lethargy, shortness of breath, headache, sore throat, aching muscles, and diarrhea and vomiting, which are not uncommon. Next slide, please. And the complications of COVID range from people who are asymptomatic, may not even know that they've had COVID, to some mild symptoms. But on the other end of that spectrum, it can be devastating. It can cause severe disease, hospitalization, including on intensive care. And of course, it can be fatal. And unfortunately, we've seen too many deaths from this pandemic. And the risk of developing these complications increase with both age and with the presence of underlying health conditions, chronic kidney disease being one of those risk factors. And the important thing to understand is that this isn't a disease just of the respiratory system. It's also a disease which can affect many parts of the body. We've seen that COVID has caused venous thromboembolism, which are clots within the blood system, heart, liver, and kidney problems, neurological problems, coagulation problems, inability to clot properly or actually to overclot, respiratory failure, multi-organ failure, and of course, septic shock. So this is a broad spectrum of the way that it affects different people in different ways. Next slide, please. So we've prepared an infographic video for you, a short cartoon which will explain to you how the vaccine works. And I think understanding how the vaccine works is important to give you the confidence that this therapy is both safe and effective. And for everyone who is fortunate enough to be offered the vaccine, our advice would be to take that opportunity as early as it's offered. So if we can play the video, please.
The coronavirus is a simple structure made up of a fatty capsule with some genetic material inside. This is why soap is so effective in killing the virus. The soap disrupts the fatty capsule and so dissolves the virus. The virus also has these protein spikes sticking out. This is where the virus gets its name from, corona meaning crown-like. It's these spikes that the virus uses to bind onto our body cells and invade them. The genetic code contained within the virus gives instructions to reproduce and cause harm. There is one small section of this genetic code, however, that has the instructions to make the protein spikes seen on the outside of the virus. Scientists have copied this small piece of genetic code and have turned it into a messenger molecule, or mRNA for short. It's this message that scientists have used to make the vaccine. Once the vaccine is absorbed, this molecule is easily read by the human body and can use it to make its own copies of the coronavirus spikes. Not the whole virus, just the protein spikes. These genetic instructions stay separate from your DNA and cannot be combined. As these COVID-19 spikes are made by the body, your immune system has the opportunity to recognize them and mount an attack, without the pressure of actually having a COVID-19 infection. Your immune system is tricked into thinking you're being attacked by the virus. The cells of the immune system will produce antibodies, or special proteins, that bind onto the spikes and stop the virus reproducing. Other vaccines have used a modified common cold virus to carry coronavirus antibody instructions. The body can then use them to protect itself in a similar way. the virus is disabled, so it can't reproduce or infect you. These immunity cells memorize the structure of the viral spikes, so if you catch coronavirus in the future, your body will be ready, producing antibodies straight away before the virus gets a chance to take hold.
So hopefully that gives you a visual representation of how these vaccines have been developed and how we've exploited characteristics unique to the virus that will make these tools for protecting us in the future both safe and effective. And it's important to understand why we still need this vaccine. The majority of people in the UK are still susceptible to developing COVID-19. They are still not immune to the virus because only a small proportion of the population have been exposed to it. So what the vaccine does is it prepares our immune system so that if we are subsequently exposed to the virus, we can respond to either prevent or at the very least reduce the severity of infection. And back in April 2020, the UK Vaccine Task Force was set up. This was to support research and the industry to rapidly develop and manufacture a vaccine. And despite the speed at which we've been able to have access to the vaccine, that in no way undermines the rigorous processes that have gone in to ensure that these are both safe and effective. Next slide, please. And for a vaccine of any type to be approved by a regulator, and in the case of the UK, this is the MHRA, a vaccine needs to be proven to be both safe and effective. Safe being categorized as a low risk of side effects, and effective as being able to prevent death or serious complications of the disease itself. So before we give this vaccine to the general population, clinical trials have to demonstrate its safety and efficacy before it's offered to the general population. But our understanding of the vaccine doesn't stop there. Once it's used in the general population, there are ongoing surveillance after approval to show whether the vaccine is providing long-lasting immunity, or whether we may need to booster the immune response by providing repeated doses or annual doses. And it's this ongoing work that is adding to our understanding of these therapeutic options that we have. It may allow us to understand whether people who have been vaccinated can prevent the spread of the virus, and studies into this are adding to our learning day by day, and also to understand any side effects that may be present as a result of the vaccine. Next slide. So the vaccines that we're fortunate enough to have approved in the UK and have given to significant numbers of people already, almost 7 million people, have come from two different manufacturers that use slightly different ways of producing an immune response. The first one approved since December 2020 was that produced by Pfizer. And many of you will have heard about some of the logistics problems associated with this vaccine from the fact it needs to be stored at extremely cold temperatures. This vaccine works by allowing the messenger RNA, the genetic code, to be put into a human cell and to replicate the spike proteins seen on the virus. And that primes our immune system for being able to tackle the virus should we subsequently encounter that in the future. This vaccine is being given in 2 doses, and the second dose is needed to produce a long-term protection from the effects of COVID. The second vaccine, which was approved slightly later on the 30th of December, uses a slightly different way of getting this genetic material into our cells so that we can replicate the spike protein. It uses a viral vector. That means it uses a virus to introduce this message to the body. But that virus is unable to replicate itself. So to all intents and purposes, this is not a live virus. And this is important to understand because this allows it to be given to people who may be immunosuppressed or on immunosuppressant therapies. And again, this vaccine is given in 2 doses, the second one being needed to produce longer term protection. And the interval which we know through studies, which is acceptable, is between 4 and 12 weeks. And it may be that actually increasing the interval of this vaccine may actually produce a better effect overall. Next slide, please. So the COVID vaccine, like all other vaccines, will have side effects. Unfortunately, what we've seen in clinical trials and in our practice and given this to people is that these are mild to moderate and are usually resolved within a few days of vaccination. We can expect local reactions being where the injection is put into the top of the arm, into a muscle known as the deltoid muscles. And some patients will experience redness, swelling, warmth, some tenderness around the injection site. And all of these things are common with any other vaccine, such as the flu vaccine. There may also be a wider systemic reactions that are not just affecting where the person is injected, but may affect the whole body. But again, these are mild to moderate, and they typically include things like tiredness, headaches, nausea, some muscle aches and joints. And these are the things that if you've had a flu vaccine in the past, you know will have experienced in the day or two following the vaccines. And most of these symptoms can be managed with regular doses of paracetamol. You may have heard that these vaccines do have the potential to produce anaphylaxis, an allergic reaction. Fortunately, these are extremely rare, and these vaccines are given in environments where, if this is a problem, highly trained staff and resources are on hand to make sure that the allergic reaction is immediately dealt with. Next slide. So the vaccine policy in the UK has been developed by advice from a committee known as the JCV&I, and this is the Joint Committee on Vaccinations, on Vaccines and Immunisations. And the aim of this policy is to protect those who are at most risk of serious illness or death from COVID-19. And it's the JCV&I that advise on which groups to vaccinate and also which priority order these groups should be given, so that those who are at most risk are protected sooner. Next slide, please. So you will have seen this in the news and in the mainstream media, and this is the criteria by which the JCV&I recommends that government and the NHS offer the vaccine in terms of categories that they believe would benefit most from it. And at the top, we see residents in care homes, followed by those over the age of 80 and frontline health and social care workers. Number 3, all those over the age of 75. And number 4, those over the age of 70 or have a clinically extremely vulnerable individuals, which would have previously been identified through the shielding list. And the good news is that when we look at those groups, 1, 2, 3, and 4, there is an expectation and a realistic prospect that by mid-February, the majority of people within those will have received the vaccine. Next slide, please. So when you're offered your vaccine, you will be screened and asked a series of questions by the healthcare professional that will vaccinate you. And these slides give you a sneak preview to what they are. You'll be asked, do you have any allergies, which is important for us to understand whether there's a potential risk from an allergic reaction to these vaccines. You'll also be asked whether you've had anaphylaxis, which is a severe allergic reaction to any medicines or vaccines. And that may not necessarily prevent you from having these vaccines, but it allows the person to assess that risk. You'll be asked whether you have had a vaccine in the last 7 days. And it's ideal that if you're having the COVID vaccine, that you've not received a vaccine for flu or hepatitis B or any other vaccine within the last 7 days. You'll also be asked whether you have had COVID symptoms or indeed a positive COVID test within the last 28 days. And there's a guidance to us that suggests that we should leave 28 days before having had COVID to offer in the vaccine. And of course, you'll be asked if you're feeling well today, to exclude any COVID symptoms and to make sure that there isn't an acute illness that may result in a delay to the vaccine. But there are very few illnesses that have prevented this being given in a timely fashion. Next slide, please. So we know that COVID has been a significant challenge for the whole population, but for the kidney community, COVID has been incredibly difficult. We know that people rely on dialysis services for life-saving treatments, and throughout COVID, we have had to maintain those. We know that our follow-up for transplant patients must go ahead, and we've adapted our services to make sure that we can continue to provide these things in a safe and effective way. And so the opportunity for a vaccine for the whole of the population is welcome, but particularly for our renal community, it's extremely welcome. Next slide, please. And these are some difficult statistics which are being presented here. And the reason that I've put them in there is for people to understand that COVID is a significant risk for people with CKD, with chronic kidney disease. And we know from our renal registry data and our renal association that by November 2020 across the UK, 662 people who were being treated with in-centre hemodialysis had died from COVID-19, and that represents over 3% of the population on in-centre hemodialysis. And this number of people, which is disproportionate compared to the severity of COVID in the general population, is a result of two things. The CKD itself produces an increased risk of complications, but also people who attend in-centre hemodialysis are not able to fully shield by the fact that they have to attend a dialysis centre for 2 or 3 times a week. Next slide. And for people who come in to in-centre for hemodialysis, data that our clinical authorities have gathered has showed that within 14 days of contracting COVID, the mortality rate is 20%, or 1 in 5, which is a significant number. Next slide. And when we look at the data that has been gathered in transplant recipients, we can see that 208 people across the UK who have had a kidney transplant have died from COVID-19, and that represents about 16% of those people who have contracted the disease. Next slide. So the key messages I hope you can take from this presentation is that we are still in the midst of an ongoing global COVID-19 pandemic. And locally, we know that rates are as high, if not higher, than many other parts of the UK. The best way to protect yourself from COVID is to protect yourself from the virus. Vaccines offer hope from a less severe response, but the only true way to protect yourself from COVID is to not get exposed to the virus. And this is why social distancing and adherence to COVID guidance is as important whether you've been vaccinated or not. And we cannot stress that message enough. So the vaccines have been and are continuing to be rigorously tested for both their safety and effectiveness. We know that the 2 vaccines that we're offering in the UK do not contain living organisms. They are not able to replicate and are therefore safe for people with immune system disorders, including kidney transplant recipients who receive anti-rejection medicines. People with suppressed immune systems may not always respond as well to a vaccine as those without an immune response. But what we do know from other vaccines is that there is a response. And this is the reason why, whatever the statistics are, it is important to get vaccinated and to take the vaccine which is offered to you at the earliest opportunity. The vaccines are likely to be effective at preventing severe COVID-19, but we must remember that no vaccine is 100% effective. People who have been vaccinated may still get COVID, but it's highly likely that that should be a less severe form of COVID-19. Next slide. So the vaccine will reduce your chance of suffering from COVID-19. Studies have showed high level of short-term protection, perhaps as early as 2 to 3 weeks after the first dose. But the second dose is needed to maintain this protection for the longer term. And it may be required, as we learn more about the response to these vaccines, that repeated doses may be needed in certain groups. We don't know yet if vaccines will stop you catching and passing on the virus. And so regardless of having the vaccine, it's as important to continue to follow the COVID-19 guidance to protect yourself and of course your friends and loved ones around you. And so social distancing, mask wearing and washing your hands frequently remain as important as after vaccine as it was before. Next slide, please. So the things that you need to consider now is, what will you do when called for the vaccine or offered it? My advice would be to take the vaccine as soon as it is offered. We know that it is safe and effective and offers a real hope of protecting an individual who may subsequently get exposed to the coronavirus. And if you're unsure in any way of whether, when the time comes for you to have that vaccine, that you need information, then I would suggest you contact your renal unit to have that discussion. And my advice to you would be to have it, as it would be to any friend or relative of mine. And as a frontline healthcare professional, I've been fortunate enough to have had the vaccine and without hesitation accepted that offer some weeks ago. And that concludes my presentation, and I think we're now going to hear from Brett, who's going to tell us his story.
Hi there. For those who don't know me, I'm Brett Dowd, and I'm the Patient Information and Support Manager for Kidney Wales, and I'm also dialysis for the past 11 years. So I'm here to speak about the vaccine as well, like everybody else. So I was offered the vaccine and got it last week. Due to me having other health conditions, I got it with the other patients that were in centre. And before I had the vaccine, I did actually have quite a lot of anxiety towards the vaccine. And I wasn't too sure because of all the different stories that you hear. So what I've done to help my anxiety is I actually started reading the facts and done some research. I read a lot of the Kidney Care UK's COVID vaccine facts that they've got up, and also looking at our newsletter that we've got out that simplified and actually explained it a bit more and made me feel a bit more comfortable about actually having this. So by doing it, I decided when I got the call, I would go forward for it. And I was lucky that I got mine done in my renal unit, and it was really well, basically social distancing, everything was safe. I get given an information leaflet before I got the vaccine, and vaccine was done there and then. And luckily, within half an hour, I'd left and was able to go home. I did unfortunately get side effects. I had the sore arm. It wasn't great lying, having needles in my right arm and a sore arm in my left arm trying to sleep that night. But I got through it. But my side effects weren't great. And I basically followed the guidance that was on the leaflet, and I took paracetamol and I kept myself basically just rested, and the side effects soon passed. I will admit the side effects weren't exactly great, but the main thing is that I've finally had my vaccine, and it means we are at a stage where once safe to do so, I'm going to be protected, and it means I will be able to spend time with my loved ones whenever that may be. It's definitely been a long time coming where I have really missed actually being with the ones I love, just like I'm sure many of us have, especially being in the CAV category. So yeah, basically I read up on the information, done my research, and made a decision that was right for me to go forward with the vaccine, and I'm glad I've done it. Thank you. I'll pass back to Susan.
Thank you. That was two very helpful presentations. I certainly learned a lot and was very reassured. And Brett, thank you so much for sharing your experience with us. I'm very conscious we've got lots of questions that people have put to our panel. So is it possible for our panel members to be visually shown on screen? Okay, I will assume you can all hear me, but thank you. So some of the key questions we've had relates to immunosuppressed patients, and in as much as how much protection immunosuppressed patients will receive from the vaccine in relation to the general population. And I wonder, Mike, Mike Stevens, if you would be happy to answer that question.
Yeah, it's a key one, really, isn't it? And I think it's absolutely the right thing to ask, because obviously what as Chris demonstrated in his talk, what we need for vaccines to work is for your immune system to function. And obviously, if you're on these medications that lower your immune system, for example, you've had a transplant, your immune system isn't quite as effective. It may be the case that these vaccines aren't quite as effective in patients who are on immunosuppressants, who are on anti-rejection medications, but we don't know that yet. It's likely that they still will work. They may not be quite as effective. That's the sort of the theory that most of the experts are thinking at the moment. There is some quite reassuring data that we do have, and none of it is definitive, but there is some evidence that sort of suggests that this is going to be good still for immunosuppressed patients. For example, there doesn't seem to be any difference in how effective the vaccines are according to age. So and all of us, our immune systems aren't quite so strong as we age, but yet all the trials have shown they're just as effective for older patients. And there's also some interesting data from dialysis units in London where they've had very high levels of COVID amongst their patients. And what they've seen when they've done some tests on them afterwards is that the dialysis patients are still developing antibodies against COVID that lasts for many, many months. And dialysis patients all have a degree of immunosuppression, even if you're not on the medication. So there is some evidence to suggest that this isn't going to be as much as a problem as we perhaps thought it could have been. But time is going to tell.
And just as a follow-up question, is any of the vaccines currently available better than the other for patients that are immunosuppressed?
Not as far as we know. It could be that we find that out at some point in the future, but at this point in time, there's nothing to suggest one is better than the other. And going back to what Chris said again, my advice is the same. I would suggest that you take whichever vaccine you are offered, because the two that are available in the UK, or the three that are available in the UK, we haven't been using the third one yet, but all of them have been shown to be effective. So nothing to suggest that one is better than the other for either transplant patients or dialysis patients or any other kidney patients.
And the other thing to add there is that they're both as safe. There is no safety reason why you should take one over another by virtue of being immunosuppressed or having a transplant. Neither of these preparations are able to produce live viruses or indeed result in COVID. So, like Mike said, there's no evidence or data to suggest one being better than the other in this particular group. But what we do know is that they are safe to be given.
Excellent. And when you say safe, I know one of the anxieties that some patients have voiced is that it may harm their transplanted kidney, or worst case scenario, lead to rejection. Is there any evidence that suggests that could be the case, either Chris or Mike?
Well, that question has come from someone who's really clever and thought this through, because obviously what they're thinking there is that actually if I stimulate my immune system by having a vaccine, is that going to cause a problem with rejection? So it's a very sensible question. We don't have evidence one way or another, but there's absolutely nothing to suggest that that's going to happen. We vaccinate transplant patients all the time with all sorts of other vaccines, and we haven't seen this as a problem with any other vaccines. So there really isn't anything to suggest that that's what will happen in this case. We're stimulating the immune system with the vaccination, but really we're just asking it to form a response against the coronavirus. We're not asking it to form a response against the rest of the body. So there shouldn't be any reason at all why that happens.
That's really helpful, thank you. So I think where this concern has arisen was from some reports that transplant patients haven't been involved in the original clinical trials. So people are making an assumption from that, but from what you're saying, Mike, is that there's no evidence currently, and there is no concerns because the original trials didn't have transplant patients, or did they?
No, they didn't. They didn't include, none of the trials included transplant patients, because that when you're running these big trials, you can confuse the data by including complicated patients like that. So it's true that we haven't run direct trials with transplant patients with these particular vaccines, but a lot have already been vaccinated now. That's one thing that is worth saying. Across the UK in particular, there has already been a number of vaccinations happened in transplant patients and in dialysis patients, and we're not seeing problems. The we have to be open about this, that we don't know the answer about how all these vaccines are going to work, how effective they're going to be, how long it's going to last for the immunity. And this is the reason why what we're saying is these are safe, get the vaccine. We're not expecting people to have problems from having the vaccine, but don't then think that it's all okay. Just carry on exactly as we were before, and let's see over the next few months. We'll gather the data and we'll know if and when it's going to be it's safe for us to say, right, we can start relaxing some of the other things.
Thank you. I know you're an adult transplant surgeon, Mike, but
that would be debated by some of my colleagues. Oh, you mean I transplant adult patients? Yes.
Yeah, fair point. But there has been some questions about younger people and children who've received transplants and whether or not they'll be able to receive the vaccine. Is there any comment that you or Chris can make on that?
Well, I mean, the first thing to say is that younger patients, younger people in general, are far less likely to suffer serious complications from coronavirus, even if they get it. And actually, our data from the UK, we've got a good recording system for transplant recipients around the UK. And although there have been quite a lot of infections in transplant patients, we haven't seen a single death in anyone aged under 30 in the UK who's had a transplant, which I'm not suggesting we get complacent, but it is reassuring that there's a very clear difference according to age. So the younger patients in general and children in particular are at much lower risk of serious problems from having COVID. At present, the advice, well, the suggestion is we're not going to be immunizing children with this for those reasons, because we don't think they'll gain a benefit. I've said before, and I say to a lot of my patients now, that we need to look at this as one of a number of measures, but also one of the successes we'll see from the vaccine program is by vaccinating lots of people. So we will, if we are vaccinating the whole population or good chunks of the population, we'll stop the severity of the disease, we'll stop the number of admissions into hospital, which frees up space and all the other things. So there's benefits from vaccinating as many different people as we can, really, even if you yourself aren't the one who's getting the vaccine.
Yeah, I think that's a very good message to hear. Thank you. Chris, we've had a few questions about where people are going to be receiving their vaccines, and I know you touched on that in your presentation, but would you like to answer that in specific?
Was the question where or when?
Where, yeah, where.
Where, okay. So we know that vaccines are being offered through mass vaccination centres, and we know that also the number of GPs that are offering this is being increased. So it's essentially one of those two places for the majority of people, and also some dialysis units have had the ability to vaccinate some of their patients. But in the main, this is going to be through the GP or through established mass vaccination centres.
Lovely, thank you. And just whilst we're on you, Chris, you talked about allergies in your presentation, and I think you made it very clear about how rare that would be. But we have a number of patients that have suggested or noted particular allergies that they have, for example, penicillin, iodine, nickel, things of that nature. Is there any further reassurance you can provide to those patients in relation to receiving the vaccine?
Yeah, I think the person who makes the decision to vaccinate you will have a consenting process and a screening process. And it's important that these individuals have full visibility of your allergy status. Allergies to certain medicines and sometimes vaccines that are not necessarily precluding you from having the vaccine. They give us information about your previous allergy history. And we also have two vaccines. So one which may not be suitable doesn't necessarily preclude the other. But also to bear in mind that regardless of where you have the vaccine, there are facilities to immediately deal with someone who may develop an allergy to these things. Highly trained professionals on site and available to respond if needed.
Great, thank you. Thank you. There's been a number of queries in relation to the new variants that we're hearing about in the news, the South African, the Brazilian variants, etc. Is there any further information that or reassurance you could provide in relation to how the current vaccines will be effective against these variants?
Yeah, well, I think this is an area we need to keep an eye on. I was on a call yesterday with the head of virology for transplant in the UK, who was describing the latest evidence on this. And actually, the evidence that we have so far is we think the vaccines that we've already developed are going to be effective against these new variants. That's what we think based on the evidence we've got right now, but we'll definitely have to keep an eye on that. One of the nature of viruses in general and coronaviruses in particular is that they do have this tendency to change just a little bit over time. And that's the reason why, you can get more infected with these things more than once. So it may well be the case that we have to tweak the vaccine as time goes by, that might be the way that we go in the longer term. I think somebody has written in one of the questions about whether if you've had one vaccine, you have to stay with that type for the rest of your life kind of thing. That's not necessarily the case. We could, in theory, you can have different types of vaccine, we can tweak it and you can be revaccinated. So there's a lot more to come from this in the future for sure. We definitely don't know all the answers yet. But so far, we think that the vaccines we've got are going to work against all of those different variants.
And just a follow-up question to that, because there has been concern raised that because the clinically extremely vulnerable patients have been, in effect, fast-tracked through the system to get their vaccines as quickly as possible, is there any way they're going to be disadvantaged if there's new innovation in relation to vaccines as we move forward?
Again, that's a good question. I can see why somebody might ask that, but actually, I mean, the first thing to say is you probably want to think about the now, not about the possibles. And the now is that we know these vaccines are effective, so let's get going with them. If as time goes by, we find that one type of vaccine is more effective for certain groups of patients or for different variants, then we can change our approach. And as I said, we can give further vaccines down the line, and we may well end up doing that. I don't think I think you will be advantaged by getting the vaccines sooner, not disadvantaged. I can't see any disadvantage of getting a vaccine sooner.
Thank you. And just on the space between doses, which changed from the sort of manufacturer's 3 to 4 week spacing between doses to 12 weeks as a general statement. Do you have any concerns for any of the patient groups, and particularly the transplant group, that will be an adverse step that's been taken?
Chris, shall I go for this one?
Yeah, certainly.
Yeah, so the dosing regime was changed for the general population. That's what all of us are going with at the moment. There's the rationale for that was carefully considered, and it's a little bit controversial. Not everybody necessarily agrees with it, but what the rationale is that it's a safe approach, and we will get more people vaccinated quicker, which at the end of the day is good for everybody. Actually, there's some evidence for the Oxford, for the AstraZeneca vaccine, that delaying the second dose a bit longer may actually be beneficial. So we don't, I think it's safe what we're doing at the moment. There is just one extra confusing thing that's come out this week, and that's a change, or last week it was, and that's a change in advice for patients who are, effectively, it's for us, it's for the patients who are on the transplant list. So somebody who at the moment isn't on immunosuppression, but we are expecting them at some point in the near future to become immunosuppressed. So in other words, we're expecting someone to get a transplant. The advice for those patients is that we keep the dosing as per the original manufacturer's recommendation. So 3 weeks if it's the Pfizer and 4 weeks if it's the Oxford vaccine. So it's created lots of headaches for us. As you well know, Susan, we've been on calls most of the day yesterday and today, haven't we, trying to organise how we're going to get this done in Wales. We think we've got a system that we can do that now. But effectively, for our community, we're going to have two groups. We're going to have the majority of patients who will be having it as per the rest of the UK, which is within 12 weeks. And we're going to have patients who are on the transplant waiting list who will be getting it with shorter gaps between them. And it's just the transplant waiting list. It's not people who've already been transplanted. It's just the transplant waiting list. Did that make sense?
It did. And is that more to do with making sure that transplants can go ahead in a timely way than any virology or medical reason?
There's two reasons for it. Part of it is that to try and increase safety so that we can keep our transplant programs running and get people these life-saving transplants. But actually the second part of it is that if there is a difference in how your body reacts to vaccines based on the medications that you're on, it would be better for us to get you both doses before and have your immune system in tip-top shape before we get going. So there's two parts to it, both of which make sense, and that's what we're going to be going for. If you're on the transplant list in Wales, you will be getting a letter just explaining all this to you, hopefully at some point next week. But it's a changing field, which is why we haven't been in touch with you so far.
Yeah. Thank you. Thank you. Very reassuring.
I think the other thing to add to that is that if you have been transplanted and if you're on immunosuppression, you should not adjust that because you're being vaccinated. You do exactly what you're doing now, and you make no change to that without an instruction from your nephrology or transplant centre.
Lovely. And whilst you're on, Chris, and I'm conscious of time, we've had a number of questions about the priority groups, and I know you spoke about that in your presentation, and the JCV&I recommendations mainly based on age and risk profile. But we've had a number of questions then from carers that are the sort of support mechanisms for people who are on dialysis or have had a transplant or whatever. Is there anything further that we can add in relation to that?
I think we're carers, and these are carers who are not employed in care homes, so we make that distinction, will receive their vaccines in accordance with the JVC criteria. So if you live with someone or care for someone in a home environment that has had a vaccine based on age or their clinical vulnerability, that doesn't change when you will have your vaccine. And perhaps the rationale for that is that we have to offer the vaccine to those who need it most, those who benefit most. And we don't know where the vaccination actually reduces transmission. So the evidence there to think differently doesn't exist currently. And so it's the JVC&I criteria that will be used in all instances.
Yeah, thank you. And it just highlights yet again the importance of adhering to social distancing measures, etc., even though you've had the vaccine. and both doses of the vaccine as well. I think we've asked the majority of the questions. We simply haven't had time to get through them all, but I hope that was helpful to all of the people attending this evening's conference. We've had a really good response rate, and I know there's over 100 people that are attending this conference today, which is fantastic. There will be an evaluation survey that we'll ask you to complete. You'll receive an email directly after the conference, and if you could please fill that in. It gives us the feedback that we need in order to make these conferences even more useful for you going forward. So I think there's nothing more for me to do at the moment other than to thank everybody for attending. Thank our panel and our speakers, Professor Chris Brown, Mr. Mike Stevens, Brett Dowds and Lee White. It's been an incredibly insightful conference, and thank you very much and good night.